The Congress of Neurological Surgeons is the recognized leader in neurosurgery guidelines. One of the pioneers in creating neurosurgery guidelines is Dr. Mark Hadley, who originated one of the original guidelines for the management of spinal disorders. Dr. Mark Hadley is also a past president of our organization, and today he will be presenting the recently published guidelines for the use of electrophysiological monitoring for surgery of the spinal cord. This was just published last week in our journal, Neurosurgery.
Thank you very much. Thanks, Alan and James and Brian, for the opportunity. Dr. Vellamani, you and your colleagues at WashU are doing some very good work. I congratulate you. My vintner friends in Napa, California are going to be very interested in your results. So, guidelines. This is an important issue. My colleagues and I are grateful to the Washington Committee, Guidelines Committee, their rigorous review of this work. It's been an interest of mine a long, long time. These have been approved and ratified by both the Congress and the AANS. And I'm advancing how? Green? I don't have, none of us have disclosures here. So this stuff makes sense. This is really terrific technology. And if we're going to rigorously analyze its impact on spinal cord surgery, whether intramedullary or extramedullary, we've got to look at it two ways. It's got to be looked at as a diagnostic adjunct, that is, its ability to describe the integrity of the, or lack thereof, of the spinal cord in real-time fashion during surgery. And we've got to look at it as a therapeutic adjunct. We're using this monitoring for a reason. Sure, we'd like to know throughout the course of the operation that the spinal cord structures are intact by monitoring, but if we lose them, there's an alert, then what? We're using it hopefully as a therapeutic adjunct to prevent a post-operative neurological injury or improve neurological outcome. We've got to look at it both ways. You know how this works. MEPs, SSCPs used in conjunction for this kind of pathology are the very best way to utilize monitoring, if you will. But, you know, is this a standard of care? Should we all be doing this? Well, the neurophysiologists think so. The electrodiagnosticians say so. And our pals in neurology say this use of IOM during spinal cord and spinal cord manipulation surgery is indeed a standard of care, and they'll be the first to stand up if you have an untoward outcome. And if you haven't used monitoring, they'll be the first to help point that out to our legal colleagues. Well, using rigorous methodology that's been previously described by our group and others, we looked at the facts. We're looking for Class 1 robust medical evidence, less robust but still very strong Class 2 medical evidence, and Class 3 medical evidence, case series, case reports. And you see there's a lot of work been done in monitoring as a diagnostic adjunct, and we got a bunch of Class 1 studies and Class 2 studies, and they are all in the same direction. They are all positive. Remember that. Therapeutic adjunct. Here's where the hang-up is. There hasn't been much work here, but there's been some. There are two very good comparative cohort Class 2 studies that are negative for the use of monitoring as a therapeutic adjunct, and I'll describe that. The rest, the Class 3 studies, anecdotal, expert, case series, are mixed on this issue. Very important when we're trying to establish their value from a medical evidence perspective. So here we go. Here are the results. Class 1 medical evidence supports multimodality monitoring during spinal cord surgery as a reliable and valid diagnostic adjunct to describe spinal cord integrity and is recommended if you use it for this purpose. Here's the deal. 40% of academic spinal cord surgeons use monitoring only. 65% of private practice spinal surgeons use monitoring. So a lot of us don't. It's being suggested that we're missing something by not using it maybe in the care of our patients, at least according to some of our colleagues. As a therapeutic adjunct, here's your answer. Multimodality IOM during spinal cord surgery, column surgery, does not improve gross total tumor resection or improve neurological outcome when utilized during intramedullary tumor resection procedures, the very procedure they're designed for, the one that should have perhaps the greatest impact. There has been no demonstrated therapeutic benefit, and in fact, patients with monitoring have done worse in comparative outcome cohort studies compared to those with tumors treated without monitoring. There's a bunch of Class 3 medical evidence out there, but none of it supports that there is a therapeutic relationship with neurological outcome when a monitor occurs. You can say, well, gosh, we got that monitor and we up the blood pressure, which should be up while you're doing this anyway. We raise the temperature, that should be normalized anyway during a procedure, and then we release the rod and with the overcorrected rod. Well, there are reports of that, but there's no consistent relationship between these kinds of activities after an alert and a benefit in neurologic outcome. So here's the answer for organized neurosurgery. For those of you who use monitoring and those of you who do not. Multimodality IOM use during spinal cord or spinal column surgery cannot be supported as a standard of care based on evidence-based medicine. So many of us use it, or some use it, because they feel more safe, more comfortable, knowing that the integrity may be intact, using IOM as a diagnostic adjunct for its proven Class 1 medical evidence diagnostic accuracy. And you use this according to individual surgeon discretion and case indications. Importantly for our group, the lack of use of IOM during spinal cord procedures by spinal surgeons should not be in and of itself considered substandard care, because its use does not have a therapeutic benefit during spinal cord surgery. Our goal, our hope, organized neurosurgery's goal is, let's use evidence-based medicine to help guide us with what we use to help our patients. And it makes sense this should work. My other goal is to drive the young men and women scientists out there in neurosurgery and show us how we can better utilize intraoperative monitoring as a therapeutic adjunct for the benefit of our patients. Thank you very much.